All right, well, this is going to be a quickie for mental health. Okay, so let me try to get you guys up to speed where you need to be. When we talk about psychiatric nursing, we're talking about multiple disorders. Um, Psychiatric illnesses are not typically diagnosed the way other disorders are. It's not like I can give you a blood test and find out, that you have schizophrenia or that you have bipolar disease. And so with psychiatric disorders, we use a book called the DSM-5, and it's a diagnostic manual. Basically, the way it works is we look at the patient's symptoms, and there in the manual is a set of symptoms. And if the patient has, say, 3 of the 5 that are there, we can officially diagnose them with this particular mental illness. The first one I want to talk to you about is schizophrenia. So schizophrenia is a psychosis. Psychosis or psychotic disorder refers to the symptoms that go along with it. And so with schizophrenia, here's what you need to know. There are positive and negative symptoms of schizophrenia. And by positive, I don't mean they're good, okay? They're things that you can see when you look at the patient. And then the negative symptoms are things that you can't really see, but when you start assessing the patient, then when the patient starts speaking with you, you start to find out. So, and I've uploaded also a little cheat sheet to go over schizophrenia and bipolar disorder and the antipsychotic meds and the antidepressant meds, mood stabilizers. So that'll be part 1 of this. Okay, so with schizophrenia, the positive signs of schizophrenia: 1, hallucinations. Hallucinations are seeing, hearing, or feeling things that are not there. And typically with schizophrenics, they have auditory hallucinations. They hear voices. When you're dealing with somebody who's actively hearing voices, having auditory hallucinations, some good nursing interventions are, number 1, headphones with music to kind of drown out the voices. And number 2, always ask the patient what the voices are saying to him. Because what if the voices are telling him, kill the nurse, kill the nurse? That would be important for you to know. Okay, so you've got the hallucinations, usually auditory. The next thing you have are delusions, okay? And delusions are concrete thoughts that no matter what you tell the patient, they can't let go of them. The CIA is watching every move I make. I'm the Queen of Spain. A delusion is a thought that's set in concrete in their mind, and you can't change their mind, even if you offer them facts to prove that it's not so. I'm the Queen of Spain. How can you be the Queen of Spain if you're sitting here in Northfield, New Jersey? Don't you worry about it. I'm the Queen of Spain. Delusions. And then bizarre and disorganized behavior. If I had a nickel every time the cops would bring somebody into the ER running down Pacific Avenue naked, right? Or it's 90 degrees out and the patient's walking down the street wearing a parka, okay? So these are all this bizarre behavior. These are signs, positive signs of schizophrenia. The negative signs, remember the 3 A's: anhedonia, avolition, analogia. Anhedonia, I have no joy. Nothing brings me pleasure. These are the negative symptoms. Anhedonia is no pleasure in anything. Avolition, I got no ambition. What it means is they're not motivated really to do anything unless they have a hallucination and the voice is telling them to do something. And then the last is alogia. The definition of alogia is poverty of thought or speech. So basically, other than the hallucinations and the delusions, they don't have any kind of thoughts going on in their head. They don't really have anything to talk to you about. It's just, how you doing? Usually you'll see a flat affect. We can call it flat or blunted. And it just means they're not happy, they're not sad. They basically have no emotion in their face. It's a flat or blunted affect. Okay, so with schizophrenia, with these psychotic disorders, the treatment is antipsychotics. And the antipsychotic drugs all share commonalities. I included in that cheat sheet the antipsychotic drugs that you need to know. And they include Risperdal, Haldol, Seroquel, chlorpromazine, clozapine. So those are the ones that you need to know. All of them share the potential for agranulocytosis, which means the patient is without granulocytes or without some specific types of white blood cells that help them fight off infection. And so you're going to carefully monitor the patient for signs and symptoms of infection like a sore throat, because if they do get infected, they don't have white blood cells to fight off the infection. And the other big problem is EPS, extrapyramidal symptoms or extrapyramidal syndrome. And what that means is it's a set of symptoms that are all neurological in nature. And they can start out really subtle. So in other words, they can start out with these weird involuntary movements of the mouth or the tongue or the eyes. With the eyes, it's an oculogyric crisis. They get these crazy eyes all over the place. Smacking of the lips or the tongue. So the tongue, with those involuntary movements, can eventually become tardive dyskinesia. And if they get this, it's irreversible. So you wouldn't want to spend the rest of your life with your tongue hanging out of your mouth. Okay, that's tardive dyskinesia, which is part of EPS. Other signs and symptoms are ataxia. An ataxic gait is a shuffling gait. When they walk, they can't pick their feet up. They kind of just shuffle. They slide their feet. Awkward involuntary movements of the extremities, which are akathisias. Okay, also signs of EPS. The treatment for EPS, there are two meds that are used, and you need to know these. The board will ask you. First one is benztropine. It's an anticholinergic drug. The trade name is Cogentin. And often, if somebody's on an antipsychotic, you will see them on Cogentin, benztropine, prophylactically to prevent the EPS from happening. And then the other drug that can be used to treat EPS, believe it or not, good old Benadryl, diphenhydramine. Okay? So these are things that you need to know. When it comes to treating schizophrenics, like I said, we're basically treating the symptoms, the psychotic symptoms, which are those hallucinations and delusions. And just EPS is the one thing that you really have to keep in mind with any of these antipsychotic drugs. Now, bipolar disorder. Bi means two. So bipolar, two poles. That means we used to call it manic depression. Basically, that's what it is. The patient will go through periods of either severe debilitating depression or elation, which is mania. Don't confuse a manic episode with agitation. They're not agitated. Somebody who's manic is just like somebody who just smoked a big old crack pipe. I'm going to paint the house, and we're going to get everything done today, and I'm going to... And they'll start 20,000 things, and they won't finish any of them. And they go from that extreme to such severe depression that they won't eat, or they'll stress eat and they'll just eat constantly. They won't sleep, or they'll sleep all the time, and they're just always deeply, deeply sad. They'll cry, they won't bathe, right? These are all signs of severe debilitating, major depression, major depressive episode. And with bipolar disorder, the typical drugs that we use to treat it are the antidepressant drugs. Now, within the antidepressant drugs, we've got several different subcategories. We have SSRIs, selective serotonin reuptake inhibitors, SNRIs, selective norepinephrine reuptake inhibitors, DNRIs, dopamine and norepinephrine reuptake inhibitors, MAOIs, monoamine oxidase inhibitors, and TCAs, which are tricyclic antidepressants. For the tricyclics, just remember the TCAs, they're the last resort. And the only one you need to know in that category, amitriptyline. ATI and the board is going to ask you about amitriptyline. It is very sedating, okay? And it carries with it the risk of agranulocytosis and also serotonin syndrome, which we're going to talk about in a second. With the SSRIs and the SNRIs and the DNRIs, all those guys, and the MAOIs too, they all involve neurotransmitting chemicals, norepinephrine, serotonin, and dopamine, because the thought process is that those are the neurotransmitters that are somehow out of whack with these patients, causing these severe symptoms of mania and depression. And so all these drugs that are in these categories, fluoxetine, which is Prozac, sertraline, which is Zoloft. The big one that you do need to know is bupropion. Bupropion is also known as Wellbutrin when it's an antidepressant, but it's also used for smoking cessation. And in that capacity, the trade name is Zyban, but it's still the same drug, okay? It's still bupropion. And the big problem is that a patient will sometimes receive bupropion in the form of Zyban to quit smoking. They don't realize it's an antidepressant drug. And then they'll see another physician or a psychiatrist who will prescribe them another antidepressant that affects serotonin, and the patient will then be at risk for serotonin syndrome. What is serotonin syndrome? It is an increase in the amount of serotonin in the bloodstream that causes this set of symptoms that include hypertension, tachycardia, and hyperpyrexia, which is a very high fever. Another reason that you'll see serotonin syndrome happen is that oftentimes with mental illness, bipolar disorder particularly, we will start the patient on an antidepressant and we'll give it a few months. And if they're not getting any better, the symptoms aren't getting relieved, then we will maybe stop that and give them another different one, a different category. But because they all affect serotonin and the patient typically is afraid to have those symptoms full blown again, we'll tell the patient you must wait 14 days, be off the first drug for a full 2 weeks before you start the new drug. And oftentimes they won't do that. So now they've started the new drug and they still have the old drug in their system, which increases the amount of serotonin in their blood and then causes the serotonin syndrome, which is a life-threatening event. Can put them in the hospital. All we can do with serotonin syndrome is treat the symptoms. We have to bring down that blood pressure, bring down that heart rate, bring down that fever, and just kind of ride it out until the serotonin in their bloodstream eases itself out, okay? So that's that. MAOIs, monoamine oxidase inhibitors. The only one you really need to know is phenelzine. ATI will ask you about phenelzine, also known as Nardil. And with MAOIs, if you get a question about it, I'd bet a nickel to make $1 million. It's going to be about foods containing tyramine. Tyramine is a chemical in certain foods that when a patient on an MAOI eats foods containing tyramine, it can actually trigger serotonin syndrome, okay? Foods that contain tyramine are all the delicious foods. Aged meats like pepperoni that you would put on a pizza, Slim Jim, beef jerky, dried processed meats, aged cheeses, wine, beer, and avocados. So these are foods that contain tyramine. If the patient's on an MAOI, they have to be strictly instructed to refrain from any foods that contain tyramine. Okay, and that's what you need to know about that. Last but not least, we have lithium. Lithium. When you think lithium, you think salt. Lithium is a mood stabilizing drug. It's not used for psychosis, okay? It's used for bipolar disorder, and it's also used for bipolar, mostly manic. So in other words, people that have severe mania more than the depression. And with lithium, they need regular blood work done. A therapeutic lithium level needs to be 0.8 to 1.2. Anything greater than that, the patient's becoming toxic. Early signs of toxicity are slurred speech. They're going to sound like they're drunk. And then as that toxicity starts to increase, if we don't notice those signs and symptoms of toxicity, it progresses to things like that ataxic gait, the akathisias, those involuntary jerky movements. And then it can progress to seizures and even death if we don't notice the toxicity. So we instruct a patient on lithium that they must continue to maintain an adequate salt intake because the number one risk factor is hyponatremia. A low sodium level is a huge risk factor for lithium toxicity. That's important for you to remember. So when you think lithium, You think so, okay? Don't forget that. I think that is the fastest crash course I ever did on psychotic disorders and mood disorders. There is a lot more that I have to talk to you guys about. A lot more medications as far as nervous system medications, benzos, and so on, but we will get to that in the next lecture. And that's all she wrote for right now. Peace.